Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about a case of a patient having heparin-induced thrombocytopenia.
Okay.
A 56-year-old male had come to our ER with complaints of lower limb pain.
Lower limb pain. Okay. Okay.
Left lower limb pain. On initial primary assessment, the airway is patent, breathing 18 per minute, respiratory rate, saturation 99% tumor, circulation 120 by 80 mmHg, and pulse was 72 beats per minute. Peripheral pulses are palpable. All four peripheral pulses are palpable. At this point, IV cannula was put and blood samples were taken.
Okay.
And next, coming to the disability, patient was having full GCS, E4, V5, M6, and people were bilaterally reactive.
Okay. Can you just go to the local examination? Because
local examination, patient having left lower limb tense.
Left lower limb tense swelling.
Tense swelling with pain on movement.
Pain on movement. Okay.
Right.
Okay. So what will you do in the ED when such a patient is coming with a tense swelling of the lower limb?
Initially, we should not further examine the patient because the main DD would be DVT.
Okay.
So we need to radiologically examine to.
Okay. So the first instruction that you should give that to the nurse that the patient should be in the bed. He should not be moving around. He should not be walking. So if you want to go to the washroom and all, you need to tell the nurse that he should not be moving. He should be having a absolute bed rest. So that is the worst thing, because worst thing would have happened after that, because suddenly he is going to the washroom and he can collapse after developing a pulmonary embolism. So that is the first instruction that you will give. And the same thing you should communicate to the patient also. He should be made aware that he should not be moving from the bed. Any swelling, even if you are 100% sure that it is also a cellulitis, it is always advisable to get an, as you said, a radiological evaluation by getting a Doppler. There can be a cellulitis. On top of that, there can be DVT also. So again, you need to have the risk scoring. So whatever scoring system you are using for DVT, well scoring, you can use it here and you can find out what risk is having, this patient is having for DVT. Have you done that for this patient?
Yes, sir. Score was 4 for this patient.
So 4 score indicates what?
Like a low score. 4 is the high score in DVT criteria.
Okay. So 4 score itself, it's almost you are through that. We are going to deal with a DVT patient. And next important thing, whatever you have to, whenever you are giving another consultation, surgeons, they will come and just squeeze the limb. All those movements should not be allowed. So that instruction also should be given. So that alertness should be given that, and also your colleagues, you should be made very sure you are having a possible patient who is having a suspected DVT. So DVT patient initially in the ER, I am telling not in the ward or anywhere, but in the ER, till you start your anticoagulation or whatever be it is, the patient should be on bed. Now what happened to the patient? So you started examination, the patient, there is a tense swelling of the right or left calf?
Left lower limb.
Left calf muscle. Okay.
Yes.
So what is the other investigation, other clinical examination? What is the most important other clinical examination that I wanted to do in this patient without causing any trouble to the patient or without having any risk for developing of DVT?
Plantar extension.
No. What I wanted to know, how is the peripheral pulses? So any swelling, whether we are dealing with a compartment syndrome, we don't know whether it's a compartment syndrome, whether it's a hematoma, a large hematoma that has blood and it is causing a compression. So we want to look in features of whether the patient has any evidence of compartment syndrome. So a quick distal neurovascular assessment, maybe a checking a dorsalis pedis, a checking a posterior tibial artery, or you can just ask for the sensation of the lower limb. No motor examination, but at least this part you can do. So any patient that is coming with a lower limb trauma, swelling, all those things, make sure that you are looking in for a distal neurovascular examination. Okay. So the possibilities here that the DVT is most likely here, cellulitis less likely, and a hematoma plus or minus, we don't know the history, and whether it is a compartment syndrome, we don't have anything that is collaborating with the possibility of a compartment syndrome. So I am just telling briefly regarding any swelling that is coming to the ED, lower limb swelling that is coming to the ED, unilateral limb swelling, lower limb swelling that is coming to the ED. I am not talking for anything else. Okay, fine.
Next, regarding to the secondary survey, this patient had been in a long flight travel, and he had been visited here 1 week ago with complaints of breathlessness. At that point of time, like 1 week back, the reports were showing that he had a pulmonary embolism.
Okay. Now he has got an lower limb swelling. So my question is here: have we missed an early DVT in this patient? That is the question here. Rather than taking the other way around, have we missed an early DVT?
At the time of treatment of the pulmonary embolism, we started heparin. So even if it's an early DVT, the
treatment should be right that you have said. But my question I would have been asking here that because you are giving a history of long flight travel, a long flight travel will not cause a pulmonary embolism straight away. Why there is a pulmonary embolism for a long flight travel? Because it is of DVT. So a DVT will cause a pulmonary embolism. So that DVT would have been there previously. So that is the reason why any pulmonary embolism patient that is getting admitted, you need to have a bilateral lower limb venous Doppler to be done. So my question is whether on first admission, whether have we done, whichever hospital he has been taken care for the pulmonary embolism, whether they have looked in for any evidence of DVT by doing a venous Doppler. Have they done that?
The reports at that time, they just did a HRCT and they confirmed it as pulmonary embolism and they have treated it with.
So probably this patient would have been treated by an, who has treated this patient? Which specialist has treated? Whether? Pulmonologist. Why? But it's always very important why he has developed. So it's a DVT which have been there, which was not coming out. But when you, as you said rightly, when we are treating for pulmonary embolism, automatically that DVT also get resolved. But why he is now coming back to it is the question here. So that's why we have put into some diagnosis and that's what we are discussing. So before that, to call that there was no DVT previously, we should have a radiological evaluation done before that, which we are not getting that. So if it is done, there was no DVT previously, now he has come back with a DVT, then it's a different total issue. But whether a DVT early was missed and he is coming back with a DVT again, we don't know. Even if in heparin, if it was a last DVT which we had missed, maybe they can come back. So that's one question. Still we are unable to give a correct answer. Okay.
So further, at that time during the admission for the pulmonary embolism, patient was treated with the heparin as the anticoagulant.
So pulmonary embolism treatment wise, he was given low molecular weight heparin or
heparin.
Plain unfractionated heparin. Why an unfractionated heparin? Whether there can be different modality of treatment. So when you are giving unfractionated heparin, what is the treatment? How will you give it as an? You need to give it as an infusion.
First initial start dose of 18 international units and then 0.18 infusion. International per kg per hour we start with the infusion. Then
APTT, depending upon the APTT, you will target whether to increase the dose, whether you have to increase by 20 to go to 100 or we need to decrease or we need to continue the same dose, all depend upon the APTT. So what is the target APTT that you want?
We want 1.5 to
1.5 to 2.5, that is what is target, double the normal or at least 1.5 times. For the previously it was like 40, we at least want 60 to 80. So that is what we require right now. So that is how we treat pulmonary embolism. So we are not going to discuss that. So he was treated with an unfractionated heparin. So that history is very important. So how long he was being given infusion?
He was given for 3 days hospital stay, post which he was started on oral anticoagulants.
Okay. Again, my question will be, so when will you start oral anticoagulation in case of a pulmonary embolism? So oral anticoagulation, you have got different option. You have got warfarin, you have got acetylene, you have got the novel coagulation anticoagulant agent, the newer one, rivaroxaban, all those agents are there. So what anticoagulation he has received, and if he has received an anticoagulation, from what day he has received the anticoagulation? What he has received? Warfarin? He has received apixaban. So what is the difference between, why this question is important? Warfarin and apixaban.
Apixaban acts on thrombin as the direct inhibitor and even it prevents the clot, even the clot which has been formed in that also it inhibits the thrombin.
Okay.
So it will resolve the, I mean it itself is a treatment, can be the alternative treatment for hepatic.
Okay.
Heparin induced thrombocytopenia.
Okay, fine, that is okay. We just wait with the heparin induced thrombocytopenia. We just keep it a hold. We just go ahead with the treatment and we'll come to that. My question here is, when you are planning to start warfarin? 5 days after. That is the question. If the patient was started on warfarin and somebody has stopped heparin after 3 days and he was given, started after 3 days, they have just stopped heparin, and they have just put heparin, it will take at least 5 days. That is the answer.
Yeah.
So that might be the reason a sub-therapeutic treatment for the initial pulmonary embolism, which would have triggered this DVT, and he would have come back to the ED. So that is also we need to keep in mind. But he was not started on apixaban. So when you are planning to, he was started on apixaban. So when you are planning to start warfarin, the time itself when you are starting the anticoagulation, like low molecular weight heparin or unfractionated heparin, you need to start warfarin from that day onwards itself, and you need to monitor your APTT, and simultaneously warfarin, what will you monitor?
INR.
You have to monitor the INR. So once the therapeutic range of INR develops, what is the target that you want in pulmonary embolism? 2.5 is that what we wanted. Once you reach that target, then you can stop heparin.
Yes.
Till that time, you should continue, whatever be the type of heparin, you need to continue. That will take at least 3 to 4 days, 5 days in some majority of the time, it is 5 days theoretically, but 3 to 4 days if you give, like you start with around 5 to 6 mg per kg of warfarin, around 3 to 4 days, the INR will be reaching what is required for that patient. Okay, so that is true, but here the patient was started on apixaban. So the flow of things I will just start again. The patient had an pulmonary embolism after a flight journey, which was diagnosed by a CT pulmonary angiogram, HRCT. So they went ahead with an HRCT, but usually gold standard is a CT pulmonary angiogram. Then they found out him and they started him on unfractionated heparin infusion, and he was put on apixaban and he was discharged home. Right?
Yes.
Now he has come back after a week with an swelling of his lower limb, and you diagnose it as a DVT.
Yes.
Now why he developed a DVT? That is a question. Now you answer me.
Here actually during the blood tests which were done in the primary point of care, there is a thrombocytopenia of 56,000 platelets.
Okay.
So in the background of the patient receiving heparin and patient developing thrombocytopenia within the next 4 days, we are suspecting to be an heparin-induced thrombocytopenia.
Heparin-induced thrombocytopenia. So that is the reason. So people will be concerning here, it is thrombocytopenia. Why this patient is having a DVT? So why is that? Can you explain that?
In the pathophysiology of this condition, the heparin binds with the platelets, forming heparin PF4 molecule on the platelets. The Fc of the Ig immunoglobulin combines with it, and it creates an autoimmune reaction, because of which there will be initial thrombocytopenia. But along with the autoimmune reaction, it will activate the platelets, so there can be platelet aggregation causing thrombosis. In this condition, we see majority of venous thrombosis rather than arterial thrombosis. Even arterial thrombosis can also be seen.
So the thing is that just like what we discussed in DIC, there is a coagulopathy, high risk of bleeding. There is a similar risk of thrombosis also. So DIC just doesn't mean always bleeding. There can be thrombosis. Similarly, in HIT, that is heparin-induced thrombocytopenia, there can be thrombocytopenia. That is one presentation, just thrombocytopenia, or there can be an event of thrombosis also, due to platelet aggregation, which had possibly resulted this patient in a DVT, because we haven't ruled out a DVT. That is always a question mark in my mind.
Yes.
When we have done an initial radiological investigation and there was no DVT, we would have 100% agreed that it is an heparin-induced thrombocytopenia related to thrombosis and causing this. But how we can prove that it is HIT only?
We can do there is a functional scan, and even the scans for to see the PF4 antibody levels in the body.
Okay. So can we start this?
Yes, sir.
Okay. So can you just give a briefing of what we are going to see here?
This is an article regarding heparin-induced thrombocytopenia, latest guidelines, how to diagnose it, and then what are the treatment modalities available.
Okay. So
for the actual definition wise, it is defined as the thrombocytopenia that is developed with thrombosis 5 to 10 days after heparin administration.
Okay.
Thrombocytopenia as such, they defined as more than reduced platelets more than 50% from the baseline.
Okay.
And initially there is a pre-test probability scoring system.
This is what I am, the 4T scoring system.
Yes, 4T scoring system, which
is showing in the screen in the lower half. Okay.
In this scoring system, we consider 4 T's, that is thrombocytopenia, time of the duration for the fall of the platelets, and thrombosis, and the other causes of thrombocytopenia, which we divide into 2, 1 and 0 points. The fall of thrombocytopenia fall of platelets more than 50%, or if the number of platelets, actual platelets are get like 20,000,
Okay.
then 2 points.
Okay.
In this patient, it's 56,000. It has initial platelets when he is discharged. In the outside reports, we've seen as 1,57,000.
1,57,000, and it is now 57,000. So it's more than 50%.
So we can give 2 points.
2 points for that. Okay.
And the onset was 5 days after it.
Okay.
So it is between 5 to 10. Again, 2 points can be given. And thrombosis has this query whether it can be there. We can
we can put it as thrombosis. So new onset of thrombosis, we are given again 2 points.
And other causes of thrombocytopenia in such a normal patient, there is no other causes, so this can be the likely
cause for heparin-induced thrombocytopenia. So here we have given, so totally it comes of 8 points. So whatever be the maximum score that is coming, we have taken in here.
Yes.
Okay.
After doing this pretest algorithm, then we divide it into low or intermediate or high score. So
Okay.
Next page.
Previous or next?
Next.
Okay.
The low or high scoring.
Yeah.
If it is low, we could have continued heparin.
Okay.
But as this patient is having very high risk, we have to stop heparin,
Which we are already done.
which he had already done. And we should start non-heparin anticoagulants.
Okay.
That is the treatment management wise. For the diagnostic part, we need to send PF4 heparin immunoassay.
PF4 immunoassay, that's what means written here.
The assay is just a theoretical, is a scan. If it is positive, again we need to send the functional assays.
Okay.
Which are like serotonin functional assay. If that is showing in high titers, then it means that the patient right now is undergoing heparin-induced
Thrombocytopenia. So, can we go to the previous one? Okay. So now my question is how you will prevent an heparin-induced thrombocytopenia. So once you hear this presentation, the people will think that we should not ever use heparin. But heparin is a very good drug. We need to, but the incidence is very less, very low. But heparin-induced thrombocytopenia, how will you prevent? Then, if at all it happens, how will you manage? A brief part you have already said. Because we need to continue anticoagulation also, so you can go ahead with the newer anticoagulants or fondaparinux, or which are least likely to cause heparin-induced thrombocytopenia. So, which is the drug that is most common to cause is unfractionated heparin. So, the studies have shown that unfractionated heparin will cause us more, then followed by low molecular weight heparin, and the newer agents, there is no much report on it causing an heparin-induced thrombocytopenia because the mechanism is totally different. How will you prevent it?
Management is first to stop the heparin.
Yes.
And along with stopping it, as the patient is requiring the anticoagulation, we need to start the other anticoagulant which does not have the cross reactivity to the autoimmunity.
Okay.
And the other thing, we should even stop the formation of autoantibody PF4 complexes. If the patient is having high levels of in the functional assay, we can start high dose IVIG immunoglobulins, steroids, or plasmapheresis can be done.
That will be the worst scenario. If the worst scenario, if the patient is still having complications and all those things, high dose steroids, immunoglobulin, because an antibody mediator response. So similarly, how will you treat like an immuno ITP and all those things? IVIG, plasmapheresis, and a high dose pulse steroids. That is the recommendation, and the patient need to be moved on another anticoagulant. Okay.
Regarding the options which we have for the anticoagulation,
I think these are the one, right?
Ergatobacter, vivalirudin, tanopirenoid, fondaparinux, and direct oral anticoagulation.
Direct anticoagulation, novel agents like rivaroxaban and apixaban and dabigatran also can be tried. So previously we used to go ahead with fondaparinux, but now these newer agents, they have to be given as an injection. Now we can give this as a tablet. So the problem what we face right now is that the cost factor. That's the only issue, because the cost factor is very high when you change the patient into any of these agents. But still you can consider still our good old drug of warfarin. But the only issue is that
in the patients having heparin-induced thrombocytopenia, we should not immediately start warfarin because warfarin causes protein C inhibition.
Yes.
And during that phase, it further
worsens. So that is the only problem. So once it is done and later on phase, maybe the initial 1 or 2 weeks you can go ahead with any of this agent, but later on you can switch over to warfarin by monitoring. So the problem is this drug monitoring is very difficult, but these are all good agents. But when you look into the theory, they say that apixaban will not increase the PTINR or any of this. But when you see practically, we are seeing patients coming with these drugs having elevated PTA. So there is no like therapeutic range, like how much you need to maintain, and all those things are not there. Like for a fixed thrombosis valve, we need to valve replacement, you need to maintain like 2.53 for 2.5 for atrial fibrillation, 2.5 for pulmonary embolism. Like that, we cannot predict when we have such agents. Okay.
And the other advantage of this newer acting oral anti is we can take oral, we can discharge the patient, we don't need to keep
Be
him in
them on the hospital. That's
and
what we have
also-
done, but he has come back with an heparin-induced thrombocytopenia. So the presentation time after 5 to 10 days. So the most importantly, the first dose, second dose, you will not see any of these things. Only after 4 or 5 days only, you will start seeing this. So the immediate thing, you stop the heparin, and you really wanted an anticoagulation, you consider any of the other agents which are least potent to cause your heparin-induced thrombocytopenia.
And even if these oral anticoagulants are having any further complication, majority of the complication would be bleeding in this case because we cannot reverse these agents. We have now an antidote as idarucizumab and adenosine.
That is for your dabigatran,
Yeah.
idarucizumab. And you can also protein C concentrate. All these things are available, but it's very costly, expensive. So the good thing about heparin, we have protamine sulfate, which is cheaply and easily available. If you really have a bleeding complication, we can give that. But for even for low molecular heparin, we can try protamine sulfate, but it more works for your unfractionated heparin. Okay.
And as this is the case, whenever it is a thrombocytopenia with thrombosis, the other differential diagnosis would have been disseminated intravascular coagulopathy or ITP, or thrombocytic TTP, or even further recently because of the COVID vaccination, we had vaccine-induced thrombotic.
That's a totally different algorithm. We have to go through evaluation because we cannot say that here. Okay, fine. You have anything else? Okay. So the nutshell of whatever we have presented here is when heparin-induced thrombocytopenia, very common with your unfractionated heparin, usually happen 5 to 10 days after your initiation of your therapy. Once you suspect it, the first thing that you need to do is stop it, and it is not bleeding alone, just not thrombocytopenia, it can cause thrombosis also. And the treatment will be you change to an agent which will not produce this, either of the newer anticoagulation agent or your fondaparinux. So that's what is available. So bivalirudin and all, if you ask, it is not available these days very frequently. Fondaparinux is available, and any of this novel anticoagulant also is available.
And the other thing is phases of the HIT. There are two types of even hepatic induced thrombocytopenia. There is type 1 thrombocytopenia in which heparin, because of using of heparin itself, there can be thrombocytopenia, but that is not because of the immunological.
It is not hit.
It is not hit.
So majority of the time what we see in our ICU after 24 or 48 hours after starting heparin, there is a drop in platelet, it is not hit.
That would be considered as type 1 in that there is no antibody mediated, there is no any thromboembolic sequelae. It will be below the 4 days, 1 to 4 days itself we can see that. But if it is more than 5 days, 5 to 10 day duration with the antibody mediated, that would be type 2 hit.
Then it again thrombocytopenia with thrombosis will be there.
Thrombosis.
Okay. Okay. Fine. Thank you. Okay.